can't take the heat. They feel like they're burning up. I've actually seen guys dive out a second-story window, impale themselves on a fence, pull themselves off the fence, and still fighting. So, and people are starting to use PCP again. We're starting to see more and more of it. Okay, here's the fun part.
You are about to experience a brief simulation of a psychotic episode in a patient with schizophrenia. Schizophrenia can provide powerful experiences, especially for those undiagnosed or not being treated effectively enough. The symptoms you will experience represent a compilation of a range of sensory occurrences, as reported by actual patients. These occurrences include sights, sounds, as well as wind and even scents. If you have any discomfort during the experience, please signal a facilitator.
They can be a little OCD.
Worthless.
He's waking up now.
Oh, the phone woke him up.
Don't answer.
They'll know who you
You're a
are.
waste of
Why are you
space.
so
A
stupid?
waste of our time.
Stupid. So stupid. Worthless. We hate you.
He's gonna pick up the phone.
They'll know if you lie. Know if you lie. Something wrong. Weather.
Poison.
One voice, two voices, multiple voices, multiple
He's
voices.
hanging up. Don't eat.
Out to get you.
Poison.
They know about you.
Poison.
With an armed gunman entered the convenience store on 14th Street. The suspects were described as medium in stature with a slightly youthful demeanor. Anyone with information about this incident is urged to contact.
They know.
They know about you.
And in other news, officials have closed the northbound.
Time for meds.
Don't do that.
Repair crews are on the scene. That's a good story out of Chicago from last night. Two men posing as maintenance workers nearly made it out of the Quick Bite convenience store with the store's ATM machine.
Make a
The
list.
suspects
Make a
pulled up
longer
and
list.
entered the store and asked the
You
customers
are
not to use the
ungrateful.
machine because
You're a
it was
waste of
off.
space. A
They told
waste
the
of our
clerk that they were
time.
going to take the machine back to the
Get
shop.
our coffee now.
Don't drink it.
Sensing something
Stupid. So
suspicious, the clerk
stupid.
That
called
smells
the
awful.
police.
Don't drink that coffee.
When the clerk told the men he had called police, the pair took off and left the machine.
Why are you so worthless?
So Scott, tell us how this weekend's weather.
Weather. Something wrong.
You know what, Chuck? There's just no stopping the weekend weather. You hear that, worthless? Weather's coming to get you.
Something wrong. Weather.
Hey, what are you gonna do about it, huh?
Something wrong.
You have to stop it.
You're just gonna sit around, your stupid mouth open and do nothing?
You have to stop it. It's the weather. It's here for
Now
us.
he has to answer the door.
It's here for us. Do something. Stay in. Stay away from the
No,
door.
stop the weather. Protect us.
You didn't order anything.
No, don't answer.
You're stupid to open that door.
He has to open the door now.
Let's see how to stop this. You can imagine if the psychotic break, if you close your eyes and just listen to this. This pizza guy could be in danger, not have a clue about this guy. He hasn't taken his medications. He's now responding to all this internal stimuli. He could open the door and assault this guy. This guy wouldn't have a clue. They can become so psychotic that way.
Here you go.
Don't do it.
You'll be in trouble. Poison.
This is for you.
This is for you. He's working with them. He's part of the plot. This is for you. Shut the door. Shut it. Don't eat it. Poison. You're stupid to open. I hate you. We hate
Some
you.
items on today's activities calendar.
And you need some activities, especially when you're lazy and you sleep too much. Stop staring at me.
I know what you're thinking.
He knows. You can't stop
They're
it.
coming for you. You know that.
Part of the plot. Your mind.
Because you're so ungrateful.
Don't eat it. Poison.
No, 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 don't open
He
it.
has to open the
This
box.
is entirely your fault.
Don't eat it. Don't eat it. Poison. Poison.
They're here, and it's all your fault.
Oh, oh.
No, no, no.
They know it's you. You're in
Don't
control.
open the
You
door.
hear that?
No, no, no. Don't open it. Don't open it.
They're here, and it's all your fault.
You did it.
You should have used your mind to stop it.
Stop it. You have to take control.
Stop the door.
Hi, you all right in here? I called you, why didn't you answer? I was like screaming, it's Lorraine, it's Lorraine! Into the phone at the top of my lungs. What were you watching? Do you even remember? Did the pizza oh, what happened here? Forget to take your medicine this morning. Well, you know it's not good to miss a dose. Well, it's not too late to take it now. Let's get back on track. And why are you standing here in the dark? It's a beautiful day outside. Let some sunlight in. You need to get outside and enjoy it.
This experience is intended to heighten your awareness of the conditions affecting breakthrough symptoms in patients with schizophrenia, who may be in need of efficacious treatments. It is not meant to suggest that all of the symptoms depicted here are displayed by all schizophrenics. There is no typical case of schizophrenia.
You could just hit escape up there, it'll shrink through that.
Okay, well, you see, sometimes I want to see an interview over here. And you can look these up yourself here. Let's just try this one.
There's going to be a hearing tomorrow to see whether or not there's any legal basis why you have to stay here.
I'm not crazy.
If it was up to you, would you like to leave the hospital tomorrow?
I'd like to leave the hospital tomorrow because I've got things I gotta do.
This is a real patient.
Okay, well, I'm
It's the first of the
going to
month and
be,
there's a lot of rent to be paid and all that.
okay, what brought you into the hospital?
I turned myself in on a 5150 because I felt like killing myself.
5150 is.
Okay, so you came here voluntarily.
So I could stop from killing myself.
And what was going on that you felt like killing
It was
yourself?
3 o'clock in the morning, I couldn't sleep, all the same thoughts kept racing through my mind over and over and over again. I just wanted them to stop, period. And I thought, well, if I kill myself, I'll stop thinking. And I thought, well, that isn't too good of an idea either because you've got friends and people around you who love you. So I stopped that thought. And I said, well, who am I going to call? And I called up Ghostbusters. I mean, no, that came out wrong. It's a joke. I didn't call Ghostbusters. I called a crisis intervention center. I talked to them on the phone. They said there was nothing they could do for me for one night. So I wound up here by ambulance. Paid an ambulance to take me.
Okay.
Because the crisis intervention couldn't do anything for me.
Have you ever made any suicide attempts?
Oh yeah, I have. A couple of them when I was 19.
Okay.
Mm-hmm.
Are you usually able to ask for help when you start feeling like that?
No, I was never able to ask for help before.
Okay, so this is a new thing.
This is a
You're
new
coming
thing
into
for
the
me.
hospital.
Yeah, the way
Okay.
I came in here is not as unlike any other way I've ever come into a hospital. Asking people to please help me. so I do not kill myself.
That's all the questions I have for
Okay,
right now.
can I go back in now? Yeah, I'm getting very uncomfortable out here. I think somebody might be trying to shoot me. Somebody might be trying to kill me.
I got TV tooth, they call it. TV tooth is when they surprise you, they put little needles in your scalp. And they listen to you for years if you know it or not. I didn't know it. And they have this really fantastic, expensive equipment they touched me with. They said to me, hey, we can check your head, you know, for if your bump shows up bruise and the electricity's a little different across the scalp of your scalp, we'll guarantee you Social Security from that injury on its own. It's considered like cerebral palsy, but it would be muscular dystrophy kind of thing. And so I said, no, think about it. The next day, I said, did you think about it? Get it right, you know. And all that. I said, well, okay, I'll look at it. Okay, let's go. And when they put the needle in, the last one they put in, they went like this.
RPR is tertiary syphilis. Syphilis, sexually transmitted disease, was not treated, and over the years it becomes tertiary syphilis, neurosyphilis, and it's not schizophrenic. They become extremely demented.
So when they did it, I had a thought, when they pulled them out, they pulled them out perfect, but they left a little teeny little barb in every one of the places they put me. And they recorded it. And one person who wanted it didn't. Someone else sold it to someone else, I don't know who, but they're able to give a response back because of how thick the dental is in my teeth. How thick the dental is. And with the needles, they're easy to focus a heavier field of pickup reception because of all the fillings I got.
That's real common.
And so
they think that they're being fed information or picking up radio transmissions because of fillings in their head.
I think it's people like at Stanford and technicians, wealthy technicians and people that do stuff like NASA or any of that kind of stuff. Ames Institute. I came right up to them and tried to sell them that last little one. But for the amount of money they didn't have, I should have just gave it to them.
I get to the point where I don't want to live anymore because the mental process of the mind takes over. When I think I'm doing good for a while, something mental takes over and it scares me. Years ago, I didn't do that. Years ago, I didn't have to worry about that one thing. I was one less paranoid. I mean, one less crazy. I was one less crazy. I mean, years ago, I didn't have this new mental problem. I don't know what it is. I don't know what it is, but it's pretty scary. That's why I called the police. Nobody else was doing it. But those people at 7-Eleven, they're always on the phone talking about me. Always. Especially in the summertime, nice weather. They're always talking about me, calling hospitals, Barnes, St. John's. There's a lot of doctors at not 7-Eleven, Quick Trip. You know what Quick Trip is? There's always a lot of doctors and nurses going there making form like kill her or do something to her.
Do you notice changes in your attention, with your illness?
Huh?
Do you notice changes in attention with your illness?
I'm retarded.
But do you notice having problems focusing attention or keeping your attention on things?
Yeah.
Tell me about that.
I don't know. What was that again?
When's the last time you felt good?
I don't remember. It's killing me. It's keeping me from having a boyfriend, keeping me from driving. It's killing me. Like in China or somewhere. I just believe if somebody's been suffering years ago, they should take an OD and die, because psychologically they may not want to take the OD, but to get out of their misery, they might. They fight it every night. And every day he's always fighting with me. Michael's always fighting with me. Drop dead, geek, retarded bitch. Oh, that stuff doesn't mean shit to me anymore. I'm so used to it. I do have a brain problem. But I don't have a brain tumor.
Lisa Hill. How are you doing?
I'm doing so hot. I think and feel as though people have called me here to electrocute me, judge me, put me in jail, or kill me, electrocute me because of some of the sins I've been in.
Is this a new feeling for you?
The main thing is don't get excited, but the thing is it's not a new feeling, no. I'm scared of people.
It must be very frightening for you, though. Feels like you're about to get killed.
I'm so scared I can tell you that picture's got a headache.
Can you tell me more about that? The picture has a headache for you.
You want to know?
Yes, I do.
Okay, when a sperm and egg go together to make a baby, only one sperm goes up in the egg. And when they touch, there's two contact points that touch before the other two. And then it's carried up into the egg. And when they fuse, it's like nuclear fusion, except it's human fusion. There's a mass loss of the proton. One heat abstraction goes up in the electron, spins around, comes back down into the proton to form the mind, and the mind can be reduced to one atom.
At this point, what would you like us to do for you?
I'd like you to get me off of cigarettes, get me dried out, cleaned up, so I can go home and get a job in a bakery and go to medical school.
Just gives you some idea of what goes on with these people and how they present. Let's see, how do I get back to?
On the bottom, where he is.
Say that again.
On the left at the bottom, the red PowerPoint.
Oh, thank you. So how do we treat these patients when they come in like this? And like I said, those were actual interviews, and you can, if you do click on that, you can probably click through a lot more. There's always new ones that they have up there. I've referred to both antipsychotic medications as well as neuroleptics. And they're always indicated for schizophrenia and other disorders with psychotic features. Depression is real common with psychotic features. I've also told you already that symptoms may persist even with therapy. I can never make the voices go away, but look at what we target. Excuse me. Hostility, agitation. We want them safe with themselves. We want them safe around other people. Here in Oklahoma City, just yesterday, the lady that killed her 34-year-old daughter, she thought she was possessed, stuffed a crucifix down her throat and killed her. The mother was arraigned yesterday. She believed that her daughter was possessed, and she killed her. So you can see how important medication comes into play, get these people under control. Earlier I talked about insomnia. It's right up there at the top because that's the biggest predictor of someone that's going to have a break. Try to get their delusions, their hallucinations under control, that suspiciousness. So these are the areas that you're going to occupy or target. What you don't want to do, and I said it earlier, is change who they are. That's not the goal. We don't want to stone out on an inpatient setting. I might give somebody 10 milligrams of Haldol and 5 milligrams of Ativan and put them to sleep for 20 hours, just so they can get that rest and so that we can start dealing with them. There are two types of antipsychotics. We have the first generation, or the typical antipsychotics, and then the atypical, which is the second generation. Those are newer type medications. The medications are equally effective in the treatment of psychosis. Clozapine, which is also called Clozaril, is the medication that we use for refractory schizophrenia, for people not responding to the medication. Only certain people can prescribe Clozaril. We have 2 people at the VA that can write for it. You have to be on a national registry to write for it. It is an atypical antipsychotic, but the side effects, agranulocytosis, is a big deal. These people can get sick and die. And so they do recognize that the medication is such a good medication, but because of that high risk of that medication, my medical director and his assistant are the only 2 that write for that. We have to get labs every week, and we have to document it. The choice of the neuroleptics that you use or the antipsychotic medication, whether you use a first generation or a second generation, should be made based on the past history of the response of the medication, what their predominant feature is. Are they predominantly positive features that they're presenting with, or the negative, or the mood type things? And then, of course, the side effects. They know the side effects to these medications. Schizophrenics know the antipsychotics. They know them by name. They know my side effects, and they'll argue with you as you try to prescribe them. At least 2 weeks, when I was talking earlier about how long an exacerbation can last, 2 weeks of treatment is required to get that serum level up, and then we start backing it back down. Now, this last sentence here, the use of more than one antipsychotic agent at a time has not been shown to increase efficacy. Change that to atypical antipsychotic, the second generation. We do use multiple first generation antipsychotic. I'll use Haldol and Prolixin, which is flufenazine. I do use multiple first generation. It is true that there is no current literature that supports using 2 atypicals. Your risperidone, your geodone, your Seroquel, haloperidol, which is or even haloperidone, which is your Invega Sustenna. So all the atypicals, there is no current literature that supports using, and they're very expensive. But we do use, a lot of times we'll use multiple first generation, the Haldol, the flufenazine, the Prolixin, those types of things. And then add a atypical to it. And the neat thing about the antipsychotics is we do divide the doses. Now that when you have multiple doses, either BID or QID 2 to 4 times a day, that almost automatically guarantees what? Non-compliance. They may get that first dose in and they may get that second dose in at bedtime, but they miss those 2 in between doses. So typically, in an inpatient setting, we'll dose them like this, get them up, and then we'll back them back down. Or give them a really high initial dose and then back them down so we get to that therapeutic. As I said before, this is not a PRN medication as needed. This is a daily medication. It's a treatment regimen and needs to be followed. If you come in and you're extremely agitated, we will combine the benzodiazepines, Ativan, which is lorazepam. We'll use a short-acting benzodiazepine to get you calmed down while you're on the floor. There are some people that will discharge on a short-acting benzodiazepine. My recommendation is never to do that. You're more likely to create an addicted patient by using short-acting. They're going to use more and more of the medication. If you do write for a benzodiazepine and you're going to put them on it for long-term, which I don't agree with either, but Clonazepam or Klonopin is the way to go. That's a long-acting benzodiazepine, 40 to 60-hour half-life versus a 4-hour half-life with the Ativan. The thing that you want to watch out with Ativan or lorazepam, inpatient, and Mark will tell you this, that you get to 4 to 6 milligrams over a period of time, but you get closer to that 8 milligram or 10 milligram, you have a paradoxical response, so you're trying to calm them down. They're not calming down, you keep giving them more Ativan, somebody comes off shift, a new provider comes on, gives them some more Ativan, and now you've created this monster. So be aware of what's going on and how much medication has been on board. All the medications are available orally. We do write for, and I do have, I'm a medical leader for MICM, which is Mental Health Intensive Case Management. I have several hats at the VA. I see patients on Telemed in Wichita Falls, Texas. I'm the medical leader for MICM, which is kind of like Red Rock, the PAC team. So I have patients in the community that are seen daily by nurses and social workers. So they contact me. We have 68 patients that I manage that way. A lot of them, these are significantly impaired, mentally impaired patients. And so I got a lot of those patients on injectable because of the non-compliance. My goal is to keep them out of acute care. In that program, it's a community-based program. So I use a lot of the injectable atypicals. They come in every 2 weeks, 3 weeks, 28 days. I've got 3-month injectables, which is the new. The atypicals have just gotten better. Not a whole lot of new atypicals are out there. Initially, paliperidone was a pill, and then they went with injectable Invega Sustenna, which is a 28-day shot. Now they have Invega Sustenna, Trinza, which is a 3-month shot. And these people do very, very well. That way they can't get rid of medication. So injectables are a good way to go. Haldol Decanate, which is, and then the fluphenazine, which is Prolixin, are great injectables. Those are first-generation shots. And this really keeps them under control. First generation works great for the positive features, and atypicals work great for the negative aspects. I just threw this in there just to give you some idea of the parasympathetic nervous system stimulates the tears, salivary gland, smooth muscle. This is your relaxation. When we use these medications, especially the first generation, they're fairly potent anticholinergics, so the side effects are going to be just the opposite of what you see here: constipation, dry eyes, dry mouth. The more potent they get, you get the cognitive dysfunction as it crosses the blood-brain barrier. So you need to be aware of what you're given and how it's going to affect them. Because the patient knows. These people know, like I said. And they'll tell you, and they'll be right up front, I can't take that. The older guys, urinary retention with a significant antipsychotic medication causes all kinds of problems. This isn't just treating schizophrenia. Dry mouth, not a big deal until you start getting these dental caries. You notice in that one film, the guy, when you're looking at people, methamphetamine, there's nothing organic about methamphetamine. It's a chemical. It's cooked, so it doesn't metabolize in the system. The only way it gets out of your system is by eating its way out. So you see people with poor dentation, the teeth fall out, these huge abscesses. The hookers on the street in Sacramento used to hide their stashes in their abscesses because I'd get to the scene of an accident and go, oh geez, you gotta quit bleeding, I'll go work traffic and wait for the ambulance because I don't want to look at something nasty. Now that I'm in medicine, that's cool stuff, so. But, so that guy, the first guy that you saw, did someone just raise their hand? That first guy that you saw, his dentation was bad and probably a good indicator that he was on meth. But constipation, you know, you think, oh, it's just medication. Well, one of the most common presenting facts for colon cancer is constipation, especially in an elderly person. You will probably learn when you do GI that if you get a 60, 65-year-old person come in complaining of constipation, you should never ever start automatically on a laxative. You need to rule out cancer. So you don't want to create more problems. Urinary retention is going to put somebody in renal failure. Kidneys actually function to retain water, not to get rid of water. Only gets rid of what the body doesn't need. So you put something into urinary retention, it backs up. The kidneys no longer get rid of water. You put a catheter in someone, you drain their bladder, and they go into post-obstructive diuresis where the kidneys are just dumping everything. Then you have all kinds of problems with cardiac issues and stuff. So the side effects to the medications are important to address and be aware of. It could be a domino effect. You guys know about EP and autonomic motor activity reflex. The psychotropics will affect these, and we watch for that. We'll titrate medications to EPS and back off, or we change medications or give an anticholinergic medication to prevent them. When we get into the EP, the extrapyramidal side effects, they are reversible. You stop the offending agent or you correct it, and you take into consideration the risk versus benefit. We know who drinks coffee in the morning, don't we? Typically, one of the more rigid, troubling side effects that we see is the acute dystonia. It's rare. We can see it with the first dose, usually within the first 5 days of treatment. And you'll also see that typically occurs within 10 to 14 days. So you can see it in that time frame, but you can actually see it with the first dose. And this is an extremely painful muscle rigidity movement. It's not choreographed. There's no systematic response. There's no intention. It's not like I'm reaching for my water. These people are grimacing. They're in pain. And typically will resolve on its own if we keep them on the medication that long. Only occurs until a steady state of the dopamine blockade is achieved. What it does is it's the anticholinergic and the dopamine excess that's in the system that causes it. Medical emergency is if they start having laryngeal spasms that obstruct the airway. Those people have to be intubated. Let's see. Men are affected more than females, and we treat with the benztropine, which is Cogentin. IM and inpatient, we give pills outpatient. That's an anticholinergic medication. But remember, anticholinergic medications do just the opposite of the parasympathetic nervous system. So you can put people into retention using these medications, so just be aware of that. There's a picture of the guy, and he has no control. And when you go to YouTube, if you want to Google that, they have pictures of people, and it's pretty hard to watch. Sometimes you'll see notes or refer to induced Parkinsonian syndrome or pseudo-Parkinson's. That's directly related to the medication. It is reversible. We may send someone to neurology, but typically we recognize the possible potential side effects. So we'll go ahead and take them off of it, but they will have the upper extremity fine motor tremor, the cogwheel rigidity, the shuffle, the pillow. I mean, you think they do have Parkinson's. And in fact, once the medications are removed, the offending agent, all those symptoms do reverse, and there's no more problem. Akathisia, this is that, it feels like you're crawling out of your skin type thing. We actually use beta blockers for that, Propranolol, 20 milligrams. Anybody in this class with test anxiety, Propranolol is great for stage fright. It's kind of like the glass of red wine, kind of takes the edge off at the lower doses. It is a beta blocker, it has direct effect on the heart. So for akathisia specifically, we use the beta blocker. Tardive dyskinesia. Now, this one is not always reversible. This one can get you in trouble. If you start a patient on a medication and they end up with this, you need to stop the offending agent, not just give another medication to try to stop it. This may or may not be reversible. If you put somebody in their life where they can't stop moving their mouth and they're no longer on the medication, it'll probably come back to haunt you. So it could cost you some money. There's the clozapine again. Clozaril does not cause it, but only certain people can write for that, and that's for refractory symptoms. The longer you have them on the medication, it does increase the risk of this. It's kind of like there's a medication out there called Lamictal, lamotrigine, for mood. Is that one of your medications that you remember? What's the one thing that will take you off of it? It's the Lamictal rash. That can occur. You can be on the medication for 10 years and all of a sudden get the rash. No problems, and all of a sudden bad. So be aware of that. If there are medications, the longer you have them on, they do get at risk. Some other possible side effects, these are rare, but they can be fatal, is NMS, neuroleptic malignant syndrome. All of the antipsychotics, again, with the exception of clozapine, can produce it. These people become very, very sick very, very rapidly. Fever, 38 degrees centigrade, which is about 100.4 or higher. Autonomic dysfunction. These people are sick. They have the elevated white count. This is a true medical emergency. and if you miss it, they very well may die. Sedation, none of the schizophrenics like to be sedated. They do like being up at all hours of the night. As a police officer, I've met Jesus probably 100 times at 3 o'clock in the morning as they knock on doors. And that's how we get dispatched. You know, an unknown person knocking at the door, claiming to be Jesus. Earlier I told you the type of religious aspect of it. So they don't like to be snubbed or made to feel somnolent. Weight gain is very specific with the atypical antipsychotics, specifically Seroquel, risperidone, olanzapine, which is like Prexa. Any of the atypicals will always get an A1C, cause diabetes, weight gain, prolactinemia, or elevated prolactin levels. You guys know what makes the prolactin? Pituitary. Where does that sit? Yeah. So what's the first sign you're going to see or could see with? Say it again. Okay, yeah, but also visual disturbances as it affects the upper brain. With the low potency agency, orthostatic hypotension, have these people get up slowly. They occasionally have some positional hypotension, but it's usually orthostatic. Getting up out of bed, especially if they have to go to the bathroom at night, jump out of bed and faint, have a syncopal episode, or just get so dizzy they've got to sit down before they fall down. We always look at, especially with the atypicals, QT prolongation. We get EKGs with these people because of the possible arrhythmias that are associated with them. Sexual side effects, those are rare. Retrograde ejaculation is not a more common one. It's actually fairly rare. ED, not able to get an erection suitable for the course, happens. The one that can make you go blind, retinitis pigmentosa, very rare side effect. We see that with one of the older first generation medications. And then of course with the lactorrhea, the gynecomastia, and in females, irregular menstrual cycles, and that's due to the prolactin level. Average, the normal range prolactin for males up to about 15 to 18, somewhere around there. Females, it's a little bit higher. Typically, when you'll get a rise in the prolactin level, it should come down closer to baseline if it stays elevated. I've got a patient right now that I'm going to go ahead and switch, but for the past year, his prolactin has been 48 to 51. Hasn't gotten much higher, but he's starting to get mammograms. And so I'm going to keep him on the medication, but I'm going to back the dose down because he's so stable on it, and see if I can't get the prolactinemia to resolve. If I can't, I'll have to switch. If it gets too high, go ahead and take him off of it anyway. It should return on its own. Rarely do we need to use bromocriptine or anything to resolve it. Yeah, if you take people off the medications too fast, we usually cross-titrate medications when we're going from one neuroleptic to another, or from one generation to another. So watch for the side effects there. Because the atypicals are newer, they have less side effect profile over the older first generation. Although, like I said, the older generation puts something on Haldol. Haldol's not, it's haloperidol now. But put them on that to control those positive features. The atypicals do alleviate the negative symptoms quite well, but you don't have as much of the EPS and retarded dyskinesia that we see. And like I just said, no sustained elevation of the prolactin. It will go up, but it should start trending down to baseline. Plausimeril, I've already talked to you about that. It's not a first line, it's strictly for refractory patients. The agranulocytosis can be fatal. So only, and like I said, the VA, we only have 2 people that wrote for it. Risperidone is a great drug, I like it. We don't use it in juveniles, of course I don't even treat juveniles. But this is one of the bigger ones that we see with some of the gynecomastia, some of the sexual axis side effects that occur, and they don't like the fatigue and sedation. Olanzapine and Zyprexa, as I had indicated, these medications work. It's just like any NSAID out there, I think. Pick what you like. Some of them are weight neutral. Some things you have to Geodone. It's rare that I write somebody on a Geodone, but it does work. Just pick 2 or 3 and stick with them, learn about them, because all the medications do work. The efficacy isn't really one is better than the other. It's just one may be tolerable more than the other in the side effects. Olanzapine is dosed at bedtime. Seroquel is dosed at bedtime. Seroquel, if you read the product information, you start out at 25 milligrams. I've never ever started someone on Seroquel at 25. I start at 200 at bedtime. But the product information, there are some people that I will titrate down, but usually there's no benefit until I start getting to the 200 range. And in fact, it's so common to start at 200 that if I want to start someone less than 200, that's a non-formulary medication, and I've got to give a reason for it. The big thing about the Seroquel or the quetiapine, those are sold on the street, but can cause cataracts in the higher doses. So make sure patients are aware of that and should watch them. Yes, sir.
What do the people like to use it with on the street? Do they like to combine it? I'm just curious, what's the popular thing right now?
Well, because it makes them feel better, especially if they're coming down off illicit drugs.
So they're using it actually to treat side effects of their illicit use.
That's correct.
Okay.
Zyprazidone, which is Geodone, Zelvex is another brand, but Geodone is the more common one. What do we treat the symptoms with? The unwanted symptoms, the side effects. Benztropine is the most common, which is Cogentin. 2 to 4 milligrams BID, 1 to 2 milligrams we start. And it's an anticholinergic. Artane I use for refractory people to Cogentin. I rarely use diphenhydramine, which is just strictly Benadryl. Amantadine, you guys recognize that name? That's used to treat the flu. But we use it also we use a lot of medications in psychiatry for the side effects. Trazodone, which is an antidepressant, you guys probably learned. We use it for sleep. Rarely do I've never given it to somebody as an antidepressant. All these medications have a lot of side effect profile. If you look at them in any of your literature, the profile is just amazing. It could cause somnolence or it could keep you awake. You just never know until you try it. So benztropine I use, the Artane I use, those are about the only two I ever use, or then I take them off if I can't get their symptoms under control. Remember, akathisia is a beta blocker. The actual, if you give somebody with akathisia, if you give them an anticholinergic, it can actually increase the symptoms, make it worse. This is all pretty much basic, the peripheral versus the central. Just some of the things to look out for. The central nervous system, it will cross the blood-brain barrier, so you get the delirium and the cognitive dysfunction associated with that. Because of the anticholinergic effect, narrow-angle glaucoma is an absolute contraindication. Amantadine does not have the anticholinergic effect. And I don't think it's even recommended for type A influenza anymore. It's just me. Okay, so earlier I said that we cross-titrate, gradually reduce the dose of the first antipsychotic while I'm bringing up the dose of the new antipsychotic. When I'm going from a first generation to a second generation, from a typical to an atypical, I overlap. There's no reduction in the dose of the first medication until the new antipsychotic is at full therapeutic doses. And that can take, like I said, 4 to 7 weeks. I have them on. So, like I said, there's no current literature that supports 2 atypicals, but we do use typical or first generation with second generation frequently. If you're getting no response, yeah, some of these people do cheat their medication. That's rare. Those people are usually institutionalized and they're just trying to get one over on the nurses and doctors there. But we will go to liquid or injectable with these people. And you go into their trash can and find all their medications. This is the reason why we admit and this is just kind of a synopsis. Remember, schizophrenia is a chronic disorder. I can never completely stop certain symptoms, but we can get them so that they're not bothersome, and that's what you want to ask them. Yeah, I still hear voices, but it's not bothersome. That's good enough for me. Sometimes you screw up good trying to make them better. And if any of you guys go into the surgery, remember that one. You can chase bleeders forever. Many of the more dramatic and acute symptoms disappear with time, but it is a chronically medication, and these people do spend a lot of time in hospitals. That goes without saying, the contact with law enforcement. And usually it's for, these guys are not sophisticated enough to commit big crimes. Your shoplifting crimes, they can be felonies if you get into the store with the intent to commit theft, because that becomes a burglary. So they could end up serving time in state prison for what most people would consider to be just a petty theft or shoplifting. They could be drunk or so weird on the street. Oklahoma City, most big cities, I think Shawnee does, they have a crisis intervention team, CIT officers now. Most police departments. I mean, I've arrested people for drunk driving at 10 o'clock in the morning that were probably diabetic reaction, but I didn't know, because back in the 80s, late 70s and 80s, we didn't have that experience or knowledge. We now have police officers that are specially trained, so if there is a psychotic person or a mental health patient, you can request a CIT officer. They're specially trained, they can talk people down they can distinguish whether this is a psychotic break. Somebody in severe psychosis belongs in a hospital, not a county jail, just warehouse. So their involvement with law enforcement has been decriminalized the way it should be. Most people don't need to be arrested. They have they can't form the intent of crimes. We talked about the shortened life expectancy, worst prognosis, disorganized schizophrenia, paranoid's the best. This is the reason why onset of age after 30, typically with women. If they had good social, occupational function prior to it, that's a positive prognostic factor. Marked confusion and emotional features during the acute phase. These people get upset by how they're acting. It bothers them. So they're aware, they're acutely aware of something's not right. Usually within a week or two, these people are seeking help. I just threw this slide in. It's not a big deal, but if someone comes in, if you look in all four boxes, the key there is the lorazepam. We do not use atypicals in patients with dementia, so it's actually contraindicated. If they're dementia, that's not psychotic, so we can make that worse. So. But you can always calm someone down with Ativan, 2 milligrams IM, usually calms it down pretty good. Then you can start the treatment. Typically, you're not going to start an antipsychotic in the ER. Call psych. They'll come and start it themselves or move them to a locked ward. And I just threw this slide in for the rest of these slides for information. It's not schizophrenia. You guys have already dealt with the mood disorders. But this just does give you some information on how to form a differential between them. So I'll let you guys review over these. And of course, with the mood disorders, the treatment's different with the lithium, the mood stabilizers that we use. This just gives you some information on how to distinguish a delusional person. There are things out there, global ischemic attacks, stress-inducing, especially in women, hormone changes, where they forget things, or you wonder what's going on. Are they having a stroke or whatnot? This is where this will come in, work them up appropriately. Hypochondrias. I have been to people's homes that are the people are very, very smart, but I knock on the door and the whole house is covered with tinfoil, aluminum foil. You see that in schizophrenia, trying to protect themselves. There's a paranoid aspect. Medications are covered with 5 or 6 layers of tinfoil. That's a fixed delusion. Those people, you could not convince them otherwise that these rays are not getting inside their home. But they function. They do function very well. They're usually on disability or something, so they're getting money, so they don't have to go to an outside job. They probably couldn't do that. But they can buy their own food.